morning. I'm sure you've just gone through a lot of difficult questions. It's not, looking at those questions is not easy to answer, but I'm sure at the end of the session you'll find it much more informative, and you'll be able to really look at it in a different angle. Now, my talk for today is individualized controlled ovarian stimulation. And I will concentrate on certain aspects in order to drive home the point on this particular action. Now, just to give you the objectives is to create an awareness regarding the importance of individualized controlled ovarian stimulation, and also to spread information regarding the highlights that were presented at the ESHRE meet in 2013, which was in London. Now, the importance overview of this is the importance of oocyte numbers, premature progesterone elevation, AMH, and individualized ovarian stimulation. So these are the topics that I will overview in which I will be talking about. Now, in any IVF cycle, the most important thing is the strategy to which you have to use and what exactly protocols you're going to use. Now, most often, all of us have been using the standard Agonist protocol, which has been a standard for a long time. And I think a lot of the people who are experienced in this field for a long time are very familiar with it and use it as on a regular basis. With the introduction of the antagonist protocol, you find that there has been a certain change, and that change especially has become more prominent since the 2010 Cochrane review, which said that the end results were similar between both the protocols. Now, the protocol with the antagonist has certain advantages in terms of complications. But the important thing to remember is that you are actually looking at the outcome, and that is the important thing. So you're looking at the number of oocytes or the dosage that you're going to use. So these are the things that you look at when you decide on what you're going to do. Now, most of us, you have, when you start your first IVF cycle, you have there is a doubt as to what you should start with or what is the dosage you should start with. Now, the first IVF cycle can always be a trial and error method, or you can have individualized way in which you do it. And there was one study which compared using a standard dose for everybody. They said use 150 IU for everybody, irrespective of the background. And they compared it with another group. It's a randomized trial which compared it with another group in which they looked at the background of the patients and then adjusted the dose. And they found that the outcomes were better. There was very little adjustment with regard to dosages, basically indicating that using a standard for everybody is not actually the right thing. Now, the concept of the FSH threshold, I'm sure all of you are very well aware of. Now, what happens is, in a natural cycle, you have, with follicular development, with the FSH rise, you have the follicular development. With the follicular development, you have, which goes above the threshold level. Then you have the estrogen production. And with the estrogen production, you have a negative impact on FSH production, and that brings down the FSH level. And what the effect is, basically, you have initially stimulated a large number of oocytes to grow, but only one dominant follicle happens because the FSH level has dropped. Now, this comparison is with the ovarian, when you actually stimulate the ovary. Here, what you're doing is raising the FSH level above the threshold, and it is persisting above that level. So when it is persisting above that level, you'll find that a larger number of follicles develop, and this is different as with the natural cycle. Now, in a minimal ovarian stimulation protocol, you will find that this rise is there, but the rise is not so much. It's more the persistence above the threshold which actually happens. So this is basically the concept of the FSH threshold. Now, the question that arises here is how many oocytes are actually the right number, or what are actually what you want? And that's an important question. Now, there was a study which looked at this particular thing, and basically looking at the efficiency of assisted reproductive technology. A total of 572 oocyte retrievals, yielding 7,213 oocytes, and they found that the utilization rate was 31%. Only 1/3 were actually utilized. And when you say utilization rate, you mean the number that were transferred and the number that were frozen. And if you look at it, the outcome, you find that only approximately 5% of the fresh oocytes produce a baby. So this is something which you need to keep in mind. And basically, you need to decide on what is the question that arises here is how many are actually required, or what is the best number of oocytes that you're looking for. Now, looking at this study, they looked at poor responders and high responders, and basically a retrospective cohort study, and they came up with the conclusion of 13 oocytes would give you the best pregnancy outcome. Now, here again, you'll find that this 13 oocytes gave you the best pregnancy outcome with regard to in relationship to each embryo transfer. Now, the important thing to remember here is that there is a cohort of oocytes which are sensitive to stimulation and which are considered to be of good quality. Now, if you stimulate these and these grow, then your chances of a pregnancy is higher. But if you were to hyperstimulate them, you will get a larger number of oocytes, but many of them may not be actually the sensitive ones or the good quality ones, and therefore just getting a larger number does not increase your pregnancy rate. So this is something which you need to remember, and this is your target, and that's what you're aiming for. Now, another study again looked at a similar sort of thing, and you found that, again, as the numbers went up, the pregnancy rate tended to drop. So this is an important aspect that you need to keep in mind. Now, let us look at a different angle to this, and you find that when you stimulate, you find the follicular development occurs, and with the follicular development, you have estrogen levels going up, and estrogen has a positive effect on the LH, and with the LH rise, you find that you have the development of progesterone. Now, the whole purpose of using GnRH analogs is to prevent this premature LH surge. This is what you're trying to do with the agonist protocol, but with both the protocols, analog protocols. But when you actually do it, you find that in spite of using these GnRH analogs, in some situations, you will find that there is still a subtle rise in the progesterone level. And this will be determined when you do it on the day of HCG. If you check your progesterone levels, you'll find that the progesterone levels in certain cases can be elevated. And this elevation has been found in about 5 to 35% in the agonist protocols and about 20 to 38% in the antagonist protocols. So basically saying that this elevation can be there even though you are using or you're suppressing the LH surge. Now, if you look at the outcomes and the importance of this level, you'll find that the moment it crosses 1.5, your progesterone level on the day of HCG crosses 1.5, there's a dramatic drop in the pregnancy rates. And this is seen both in the agonist as well as the antagonist protocol. So this becomes a very important factor which you need to think about. Now, the issue here is, again, another study which looked at it in pregnant women and non-pregnant women and found that in pregnant women, again, the P4 levels were lower than in non-pregnant. Similarly, the ratio also was less. So the issue is, why is there an elevation of progesterone when you have suppressed it with the analogs? And you find that it seems to be directly related to the total dose of FSH and also to the number of oocytes and also to the E2 levels, estrogen levels. So this becomes important in the sense, if you were to raise your dose of estrogen, of your stimulation, you will find that this sort of complication can happen and it will affect your outcome. Now, there's another study which is done from Taiwan, which actually looked at the duration of the P4 elevation. Normally, we look at the P4 elevation only on the day of the HCG but this particular study has looked at it from day 6 onwards, and the their cutoff was more than 1 nanogram, and they found that when the duration of the P4 progesterone levels was longer, then there was a significant reduction in the pregnancy outcomes. So this again is a very important thing. Now the question here is, how does this affect the pregnancy rate? And it is basically, it affects the endometrium, endometrial receptivity, and the synchrony between the embryo and the endometrium is lost, and that is probably the reason why the pregnancy rates come down. There was also a difference in endometrial gene expression profile between these patients. You'll find that when it is less than 1.5, it is different. When it is more than 1.5, it changes, and that is the reason for the lowered pregnancy rates, outcomes. Now, let us look at a different aspect, and that is basically the anti-Mullerian hormone. Now, most of us, when we were doing our initial studies, undergraduate, you always knew that anti-Mullerian hormone was produced by the Sertoli cells and was instrumental in Mullerian duct regression. Today, anti-Mullerian hormone is a very important investigation in women, basically looking to see with regard to ovarian reserve. Now, you'll find that the AMH is produced by the preantral and the small antral follicles, and this growth from here to here is continuous. It happens by itself, and from here onwards, it is basically by FSH stimulation. The importance of the AMH is that it is a direct test of ovarian reserve as compared to others. And that is a very important thing. It is actually a direct test, while all the others are indirect tests of ovarian reserve. The second thing is, there is no cycle variability. Intercycle, intracycle variability is not there, so you can randomly do the AMH value to make an assessment. And also, it is not affected by any drugs. So these are important aspects of AMH. Now, we look at the questions as to what is the importance of, or what is the significance of AMH with regard to these things. Now, this study looked at the different parameters or different things that you look at to make an assessment of ovarian reserve, and they compared it with actual the number of primordial follicles. So basically, the ovary was taken out, and an assessment was made with regard to the number of primordial follicles, and they found that the AMH had the best results. AFC was also similar, almost as compared to the others, the AMH had the best results. So definitely AMH is a very important investigation. Now, another study, you see that prediction of poor responders, AMH is excellent. Similarly, prediction of hyper responders, AMH is excellent. So this is better than the AFC. Here they are the same, but here it is better than the AFC. Then again, low intercycle variability, low intracycle variability, applicable to all patients as compared to others. So these are the advantages of the use of the AMH. Now, in this particular study, what they did was they used the AMH to decide on the protocol. And here you find that looking at the AMH values, this is a low AMH value, this is a high AMH value, and this is an average AMH value. In the low AMH values, they use an antagonist. Again, in the high AMH values, they used an antagonist, while in the normal AMH, they used an agonist protocol. And you found that the incidence of ovarian hyperstimulation was very low in all the cases. The pregnancy rates were reasonably good in the ones with the poor response and good in the other regions. So basically telling you that you can use this investigation to decide on how you're going to treat the patient. That's an important or a very useful parameter to help you in your decision making. Now, here again, you'll find that the AMH, when you look at it, comparisons, you find that it's compared to the other endocrine parameters. It is better than, it's equal to ovarian volume, it's better than the other parameters. All these showing that basically AMH is better than the other parameters. Now, this again, age and AMH difference is there, and basically showing that these two parameters are important. Now, the question here is, how do you match the protocol? How do you match it? Or how do you decide on in which patient to do what? And that's important. Now, usually you look at different parameters. The age is very important. Ovarian reserve can affect it or not. Then BMI has a great importance. Endometriosis will affect ovarian function. That's again important. Then, of course, polycystic ovary. And you look at all these things when you decide on actual management. Now, this is a commentary basically saying that a variety of options are there, and it should be based upon the anticipated ovarian reserve. And this is important. Now, a lot of protocols are there. All of us are aware of it. You have all these protocols, but the actual use and the dosages and the choice is what is important. So basically, you're saying that a tailored stimulation protocol based on biological variation is important, and it's not that you use the same for everybody. That is what is being emphasized. Now, what do you think about ovarian reserve? And basically, what is the importance of ovarian reserve, of this testing? The most important thing what you're looking at, all of us do, is to find out or look and see whether it's a poor responder. That's what most of us want to do. But today, there's a little bit of a difference in the sense you're also trying to find out which is the high responder, because that also will result in major complications which you're trying to avoid. So this is an important thing, and that's why you're using these ovarian reserve tests. Now, poor response, the Bologna criteria basically says anybody with an advanced maternal age or in a previous cycle they've had a poor response, less than 3 oocytes, or you have any single abnormal ovarian reserve testing. Any 2 of these, and you can call this or anticipate this as a poor responder. Now, looking at a study which looked at what's called the consort algorithm dosing study, what they did was they looked at 15 variables first to see outcomes, and then chose 4 because these were the ones that seemed to have an effect on the outcome. So they chose these 4. And using this, they decided on the dosage of gonadotrophins that were to be started. And the primary outcome was the number of oocytes that were retrieved. So this is what this particular study showed. And you will find that the outcomes over here, the pregnancy rates are almost the same in all, except in this particular one, which is a little elevated. But the important thing here is to say that the primary outcome, which was the number of oocytes that were retrieved, were the same in all these cases. So the dosage was adjusted according to these parameters, and it was each individual dose was raised only by 37.5, and it was in 18 centers. Now, what they found was that, and each person, when they made this, when they allotted that, each physician was asked to give his particular dose that he would start. So they gave their dose, and then the actual dose was calculated by this. And what they found was that in 75% of the cases, the dose that the physician gave was more than the actual dose that was given by this algorithm. So basically saying that most of us, even though we are experienced, can make a mistake when you're actually making a choice. And that is the importance of the algorithm. So looking at it here, this is basically to tell you that just because it is 187.5 and it had a high pregnancy rate, it doesn't mean that you start with this. It is based on these factors. And that's the important thing. That is what this whole thing is about. Now, again, if you look at it, you'll find that the clinical pregnancy rates were the same, and complication rates were also much less as compared to with the use of this algorithm. Now, there was another study which is known as the pivot algorithm, basically again using similar parameters, but here again it's using the AMH as well, the BMI, the age, smoking, and OHSS. And what the outcome was they found was it significantly reduced referral for intensive monitoring. So when you say a referral for intensive monitoring is when you have a doubt of polycystic ovarian syndrome developing, you have this referral of intensive monitoring. And also the incidence of OHSS was less. And when you suspect OHS, you're also likely to think in terms of not transferring and freezing all. That again was less. So basically saying that your risk of polycystic ovary or rather ovarian hyperstimulation had come down. And that's a very important thing, and this with this pivot algorithm. Now, when you look at the algorithm, it looks very complicated. Sorry, this is not the actual slide. Now, when you look at the algorithm, actually it looks very complicated. And basically, it will tell you, it is looking at all the parameters, and then you make a decision regarding what the dose is actually given. Now, other factors also that come into picture are whether there are any genetic factors which are important in this particular field. And basically, you find that when all the other parameters are normal and still you have a bad response, you're thinking in terms of is there a genetic problem as well? And you'll find that there's the FSH receptor, which is polymorphism of this has been associated with poor response. And most of the polymorphism is either it's a 680 or 307 polymorphism, and you find that the poor response, it is a poor response. So this is something which you always keep in mind. Similarly, other genetic markers also are when there's, so basically with a polymorphism, you find that there's increased basal FSH and increased dose of FSH is required. So when you don't have, when there is a poor response in spite of everything else being normal, you need to think in terms of a genetic problem. Similarly, you have this abnormality. Again, you find that when there's an increase in that, you find there's an increase in premature ovarian failure. And again, that is something which you need to think of. Now, thank you.
Okay, we thank Professor George a very condensed lecture regarding the control of ovarian stimulation. I wonder, is there any comment or question from the audience? Yeah. Actually, you know, the OSA also plays a major role for that. So you have a problem for your program, you don't show your embryologists, you think about your program firstly. So maybe I have a question to go to the Professor George. Is there any role for agonist? Can we have some predictor to those patients that are suitable for agonist instead of antagonist?
But I didn't catch your question.
I mean the agonist protocol.
Yeah,
because antagonist protocol is more friendly right now, but there should be some role for agonist protocol. So from your lecture, how about the predictors? How many predictors can we have to use as those patients that are suitable for agonist protocol?
See, it's like this. It's basically, a lot of it is a personal choice as to what your experience is and what your outcomes are. Now, when you have an agonist protocol and you compare it with the antagonist, what you're saying is the complication rates with the antagonist is less. But the outcome or the number of oocytes that you retrieve with an agonist protocol is more than with an antagonist. And that's what you always keep in mind. So you're generally, that is something which you keep in mind when you decide on your protocols. And of course, your experience, what you have been using. And a lot of people who have been using the agonist protocol continue to use that because their outcomes have been good. And a change to something new is always something which people are very careful about before they start.
Okay, great. Yes.
Thank you for your excellent speech. I got a question in terms of one of your slides. You mentioned that we can use AMH as the one of the indicators to choose your ART protocol. Do you think that that's, I mean, in your personal experience, do you think that it's a legitimate approach, or do you actually use AMH as one of your
It's like this. AMH is something which has fairly recently come into the picture. Now, it definitely, I think a lot of people now are using it in especially women whom you think that the response is not going to be better. So in those situations, it definitely it confirms the fact that you're going to have a poor response. And that will give you a change in your management. So it definitely is of importance.
Okay. Your time will allow last
Okay.
question, right?
Okay.
Professor Chai.
Thank you for your very informative lecture. I have a question about premature utilization, about your premature elevated progesterone. We know the gonadotropin, the secretion of gonadotropin is pulsatile, which means the progesterone level should be pulsatile, right? Should be pulsatile because the gonadotropin secretion is pulsatile. So since every patient did not receive the blood examination at the same time, which means that maybe the patient did not receive the injection at the same time, how do you make sure all the patient, the origin of the blood examination may be, individualized. So since the concentration of the blood is pulsatile, so how do you make sure you are checking the right time with the right concentration of the progesterone?
It's like this. See, most of these protocols which you have done, you are using a GnRH analog. So when you're using a GnRH analog, the suppression of the LH response is there. So it's so then what rise in progesterone is not because of the premature LH surge, it's because of something else. And that is what is important. So that something else is basically because of the increased dose of FSH and the response from the granulosa cells. So that is basically the reason for the progesterone elevation. It is not because of the pulsatility of the LH.
Yes, I am aware of that. In natural cycle is pulsatile, but yes, you are right. In the antagonist protocol, the natural pulsatile is suppressed. But since not all the patients have received the injection at the same time, and in a study, they didn't mention all the patients received the blood examination at the same time. So how do you make sure the progesterone can really represent all the group of the patient?
It's generally the traditional way of looking at the progesterone level is generally on the day on which you're going to give the HCG. On that day is when you actually check the progesterone level. Now, the timing of it regarding to the with regard to the actual injections, I really can't tell you that as to when it's going to happen.
Okay, save the last grade for you. May you announce your name and where do you come from?
I am Dr. Dipan, coming from India. Good morning, sir. Thank you very much for the nice lecture. I would like to answer one. I have a question in mind. Like in a non-PCOS patient, how do you decide whether you go for HMG or recombinant FSH?
That again, see, it's the choice of whether you're going to dependent on your experience as well. Now, there's a lot of controversy earlier whether urinary is better or whether recombinant is better. Now, I think if I remember correctly, all the Cochrane reviews actually say that they are same in terms of outcomes are same, and you can use the urinary products. But then this batch-to-batch variability is more likely to happen in the urinary gonadotrophins. And basically, it depends on what is your outcomes with what you have used. If you feel that you have been using the urinary and the outcome is good in patients who are with whom you do not suspect or you think would have a reasonably good response, then you can use it. It's not as if you don't have to use it.
Thank you.
Okay, I think we probably still. Okay, again, last again. Please announce your name.
From India again. Thank you, sir. Lovely presentation. There's a small clinical scenario which very invariably we come across that AMH is about 8 or 10 picomoles. That means a little over 1 nanograms. Patient is about 30 years and she shows a very good antral follicle count. Because one scenario which happened in our center that there was a new pharma guy who came and he said, my kit is excellent. So we actually did 2 AMH done by 2 different kits. And very surprisingly, out of 20 tests, 3 tests showed a marked variation. Out of 3 tests, 2 tests in our lab were showing a high AMH and his kit was showing low AMH, and in one it was reverse. So of course, prospectively, we really need to know that the AMH values, what we are getting, should we really depend on that exclusively? So how would you go about it in this case?
Yeah, there is a issue with regard to the AMH evaluation. Now you find that there are actually 2 different ways of doing it. One is the DSL method and the other is the IoT method. And both had different ways of of reporting the result. One was in picomoles, the other was in nanograms. Now, currently, both have been brought together, and currently there is only one in which it's called an AMH thing, and that is actually reporting in nanograms. Now, whether it is being done by a different center or which is a reliable center, I mean, that's a difficult question to answer. It depends on the center which is actually doing it and whether it's a proper place or a proper laboratory center where you're doing it. But there is a standardized, now it has become a standardized. Earlier, this difference was there in two different ways in assessment, but now it has become a standardized, and that is still in the process of becoming more common.
Okay, any question or comment from the audience? Because this is forum, so most of the questions and comments are very welcome for that. So probably we can move. So we thank Professor George again.